Okay, good evening, everyone. Let me let everyone in who's waiting on Zoom. Apologies, we'll just let everyone there join. And I think we're rolling live. So welcome everyone to SEMLI, essentially. SEMLI is the Sports and Exercise Medicine and Lifestyle Institute that's based at the University of Pretoria. And we're lucky enough to be hosting this event with in partnership with SASMA, the South African Sports Medicine Association, as well as Tuck Sports. So hoping that we're rolling live and everyone has joined us on Zoom as well. My name is Shona Hendricks and I'm head of sports science here at SEMLI. And I'm extremely privileged tonight to have quite the panel with me. So perhaps let me introduce my panel quickly while everyone's joining in. We're lucky enough to have Prof. Martin Schwellnus with us. Prof. Martin is the director at SEMLI. He's also a consulting sports and exercise physician at SEMLI. He's the director of the IOC Research Center in South Africa, as well as he's the chair of the IOC consensus statement, which is on a particular topic around acute respiratory infections in athletes. I'm also lucky enough to have Dr. Carolette Klutter with us. Dr. Carolette is also a sports and exercise physician at SEMLI. She's a PhD fellow with us, as well as she's served as part of the medical team for South Africa in the Paralympic Games in Rio, as well as the Commonwealth Games in Australia. And then I also have Kelly Miller, who is one of our biokineticists, and she's also a PhD fellow at SEMLI. And Kelly is also a proud ex-Tuks hockey first team captain. So I know we have a few Marty's members joining us tonight, and I'm sure there's a bit of rivalry that's there. So just some house rules for tonight, and just so everyone's aware, obviously we're lucky enough to partner with both SASMA and Tuck Sports tonight, and so we're streaming live on the SEMLI page, Facebook page, on the SASMA Facebook page, and on the Tuck Sport Facebook page. And so we also have a number of members with us here in Zoom. I see we've just clocked over 100 members here on Zoom, so that's awesome. So we're going to have a short presentation, and Prof. Martin's going to take us through that. Quite short, just a presentation, a bit of a case study, and then we'll take some questions from the floor, if I can put it like that. So if you're, whatever sort of format or platform you're on, if you could then just make sure that you put your questions in that platform. We will definitely try and get to as many questions and answers as we can tonight. Obviously, I think we have a lot to get through. And so if you put any questions down, I can assure you we'll get to every single question. We'll answer those, and we'll put that up on our SEMLI page, both our Facebook page and on our website. And then lastly, for those of you who are joining us and wanting to definitely collect your CPD points, we will send you guys that certificate, and especially if you did register with us on the Google on our Google form. So just ensure that you maybe drop us. If we didn't get your HBCSA number, I know we changed that form later on in the week, but just maybe email info@semli.co.za and just ensure that we have that. And can I just maybe ask, just from an attendance point of view, if you're with us on Zoom, just drop a little, hands up, and I'm here. Just, we have to provide HBCSA with that attendance register. But let me, that's enough talking from me. That's a lot of talking. That's 5 minutes of talking. So let me just welcome my panel here. So Prof. Martin, how are you this evening? Thank you for joining us. Oh wait, I should unmute you guys. That was really
I'm bad. Thanks, Shona. Thank you very, very much, and thank you for the opportunity to be with everyone this evening. I really look forward to the evening and the discussions.
Thank you, Martin. And Kelly and Carolette, maybe just unmute yourselves and yeah, let me just give us a good hello.
Hi, good evening, everybody. It's great to be here. Looking forward to the chat.
Good. Doc, Carolette, you with us?
There you go. Hi, everybody. It's good to see some familiar names. I don't see faces on the panel here, but I see the names, so it's good to have everybody join in.
Good stuff. Thank you so much, guys. So maybe, if we are struggling with bandwidth, it's normally a good idea if the participants keep their videos off. Sometimes that does help. But I mean, yeah, we will have our videos on, and we should be good to go. So Martin, I don't really want to waste any time because we've got a lot to get through. So maybe do you want to start getting your presentation up and loaded, and we can just ensure that we're going? I think we're all aware of the severity of the epidemic that we're facing and where we're at. And, you know, essentially we all have the health and safety of our athletes in mind here. So yeah, we can see your screen if you want to just get that slideshow rolling, and then we can take it from there. Awesome. Okay, Martin, I'm going to hand over to you. But yeah, guys, keep those questions coming in the chats, and I promise you we'll try and get to as many as we can. And if we don't get to them, we will definitely get them answered. So Martin, I'm going to hand over to you, and you can take it from here.
Shona, thank you very much. And again, thank you all for joining us this evening. We appreciate it, and we hope that we can get some really good discussion going around this topic. So the topic I was given is to talk a little bit about the medical guidelines for a very obvious and difficult problem we all face right now, which is the whole issue of COVID-19. And then where we are in a particular phase at the moment is the return to physical activity and sport. So I'm very privileged and fortunate to have Carolette and Kelly with me, and we'll talk a little bit more about what they do, and they will be able to share what they do in this whole project with you in the evening as we go along. So just a few remarks on how we're going to take this through. I'm going to make a few introductory remarks. Then I'm going to talk a little bit about a general approach to the day-to-day management of athletes. And the majority of the talk is going to focus on return to play or return to sport guide. It's not a guideline necessarily or a recommendation. It's more a few guiding principles. And I want to make the point right at the outset, this will be a guiding principles for any acute respiratory infection, including obviously COVID-19, where we are learning quite a lot in a very rapid pace at the moment. And then we'll end it up with a case and a summary and a conclusion. So a few introductory remarks, just a little bit of history. Maybe you wonder how we at SEMLI even became involved in this. Well, in the middle of 2019, last year, the IOC convened an IOC consensus group. And the topic of the consensus group was on acute respiratory illness in the athlete. And this group has in fact been working quite hard from about September last year. We have 6 subgroups, and they conduct a lot of research and work on this topic. We were going to actually have our final consensus meeting a couple of days ago in Lausanne. And of course, that all changed in December and up to date now with the COVID pandemic. Apart from the fact that some of you may have noticed that you know, the various conferences have all been postponed or cancelled. Our own meeting was also postponed for 6 months, and it's now going to take place in early 2021. What was quite obvious is that we can't have a consensus group that will present a consensus statement early next year on acute respiratory illness in the athlete and then ignore COVID-19. It was just not even remotely a possibility. So as a result of that, I've been working quite hard with the IOC. And in April, May, we started the discussions, and we have now formed a 7th subgroup that will focus on COVID-19. And the work of that subgroup will integrate into the consensus statement. Recently, the IOC has launched a website to share information. And this IOC subgroup 7 is a major contributor to the information that will be posted on this website. I think from a South African point of view, we can be very proud in the sense that there are no less than 8 people from South Africa that are on the IOC consensus group and also are members of various of the subgroups, including the subgroup 7. And 2 of them are sitting with me tonight here, Kelly and Carolette, and I'm sure Wayne is around somewhere. I think I saw his hello there. And of course, from Stellenbosch, there are a number of other very important co-workers that are working with Wayne in that particular area. So I just want to acknowledge the subgroup from South Africa, but also the subgroup as a whole. I'm just having some difficulty in advancing the slide.
Martin, just click back on click on your slide on the Zoom side, and then you should be able to. So make sure you're in Zoom, and then you'll be able to click on.
Okay, there we go.
There we go, yeah.
So just a few introductory remarks. I mean, this is just a world map coming from the WHO from a few days ago. talking about how the number of cases have just affected all of us. So that's one major, pandemic medical problem. But just from an information management point of view, this is again from the 4th of June, so it's changed already, that if you put in PubMed and you search COVID-19 just in 2020, a few days ago you found about 14,000 articles. But here's the problem, and this is the problem that the subgroup 7 is facing, is that, a few days ago, there were only 11 publications that linked COVID-19 to sport or athlete. So the question really is for us, and I'm going to bring it down to the discussion this evening, with so little, or in fact zero or no data, how do we as clinicians now approach the day-to-day management of our athletes, either you as an individual, or if you're a member of a team, or you're responsible for a whole group of athletes in a federation. So where we are in South Africa right now is that we're still in the middle of the pandemic. In fact, we haven't hit, as everybody knows, the peak yet. That's to come in the next few months. The lockdown is lifting and sport is returning back to training and competition. So the question is, if I am responsible for a group of athletes in this current pandemic, how do I now approach an athlete? What do I need to consider in an athlete? So this is my first practical maybe slide. We are facing the same problem with our tuck sport athletes, but I've get a number of phone calls and discussions both nationally and internationally about how do you do that in your team. So the first practical thing is, what is very important to know about your athlete every single day? You can even apply this to yourself if you're an active individual. The first question is, what is my health status generally? So we need to understand and know that we may or may not have comorbidities in our athletes, and young athletes may have comorbidities like asthma as an example. The second thing is, where am I with my potential or actual COVID-19 status? And so there are 4 things to know from your athletes every day. Do they have any symptoms of an acute respiratory illness? And know, of course, that not all symptoms of an acute respiratory illness are COVID-19, but in the current pandemic, we have to think about that. From a measurement point of view that the athlete can do themselves is, does the athlete have a fever? And that's put in here simply to make the point that anywhere in South Africa, when you're moving and around the world, the symptoms and the fever screen are part of a normal daily activity now. The next question is, did I need one, or did I have, because of screening, a diagnostic test for COVID, and what was the status of that, positive or negative? And then also, what is my risk that I am in the zone of about 2 weeks of developing COVID? And the obvious things that we all know are things like recent contact travel, community risk, what is the prevalence of COVID in the community that I'm in? And to what extent does an individual athlete adhere to the actual public health guidelines? And I don't have to go through all of those. Then the third thing would be, what is the plan for the day or the week with respect to training, the training status? So these are very important 3 main issues that are guiding our decision-making around athletes every day. As far as the symptom list is concerned, and I want to give credit here to Kelly and Carolette who have helped develop this symptom checklist. And it's based on a symptom checklist that they developed because they're busy with their PhDs, and this was all in the middle of this, and the PhDs were on, or still are on, acute respiratory illness. So what we've done is we've divided the symptoms into 3 groups: nose and throat symptoms, and then chest, head and neck symptoms, and systemic symptoms. And they are listed here, and I'm not going to go through each one. But this is the kind of checklist that probably every athlete should go through every day. Then the second component is the severity of those symptoms. And so we use a score, an international score. The Wisconsin score goes from 1 to 7. And we either get an athlete to tick the 0 if there's no symptom, that's obviously green and fine, or the severity ranging from very mild 1 to severe 7. And severity, together with the nature of the symptom, and then the last part is if this symptom is recurrent from a day-to-day basis, in other words, duration of the symptom, that combination of those 3 things bring you closer to whether you are in a symptomatic highly suspicious of an infection in general or COVID specifically. All right, so if you do this and ask these questions, then you can probably have three groups of athletes in your squad. Those that are asymptomatic with no fever and no symptoms. They may or may not have been tested, and the test may have been positive or negative. And I'm not suggesting that every asymptomatic person needs to be tested, but some professional sports that are returning in Europe particularly require a COVID test irrespective before they start. And in professional sport in South Africa, that may or may not may also be the case. The second group, which I'm not going to discuss, would be the currently symptomatic, the acutely ill athletes. In that case, they may or may not be tested for COVID, and in South Africa, we're heading towards not testing everyone, and the test may either be positive or negative for COVID. I want to focus the rest of the discussion and this evening, I think, on what about those that have been symptomatic and are now deemed to be recovered from a recent, and it's not recent COVID only, but a recent acute respiratory infection. Now, they may or may not have been tested for COVID, so we may or may not know the COVID status or the pathogen. And that's an important consideration because particularly in the current situation we are, and in the situation that many European countries were at the height of their pandemic problem, the testing was not routinely done. So I'm going to focus on this group and talk through the medical decision-making in return to play or return to sport. So let me start off with a few general remarks. Many of these are obvious and you know them. Well, before COVID-19, we did not really have any good evidence-based return to play, return to sport guidelines. And that is one of the reasons why the IOC has convened an expert group to actually try and deal with this. The so-called neck check, which has been applied for many, many years, was not well researched and in fact is been increasingly challenged in the last year or two or three maybe. The problem is, as I've indicated earlier, with COVID-19, we have even less data. In fact, with return to play or return to sport, we have no data. I am going to go through a number of return to play protocols that were recently published. And I mean, when I say recently published, in the last 4 to 6 weeks or so. And probably as I'm speaking, and I actually am aware of some of them, there are a few more of these protocols in various stages of review in the journals. And it's not impossible that as I'm speaking, somebody can phone in and say, well, something was published this afternoon and I didn't pick it up. However, I think, and again, under the general remarks, it's very important to understand that these return to play so-called protocols are all expert opinion. Group of people that have got expertise, and they are really good people around the world that have done this, but it is expert opinion at best. So let me just say that whatever I'm saying from here onwards is perhaps falls into that category, except that maybe I'm not that an expert as other people are. So it is still an opinion. So let me put some of these up, and I'm happy, if you haven't got the references of these, I can supply those and we can share them. But the German group, published in the German Sports Medicine Journal, brought out the first guidelines in preparation for their return of their first division football. And they indicate they have a return to play protocol that is published. And you're welcome, and I would encourage anyone who really wants to go and study that. A second one was published more as a blog on BJSM, written by John Dresner and Aaron Baggish, and they put some principles together, mostly from a cardiological side. There was a Portuguese group from Lisbon that published some return to play guidelines, if you like, in an editorial in BJSM. And then Keith Stokes and his workers in the UK recently, 2 weeks ago or so, published as part of a paper on general guidelines, also this algorithm with some return to play guidelines for infections. And then most recently, the European Cardiology Group published a return to play protocol focused almost exclusively on the cardiovascular screening and return to play guidelines. And this is worth studying. It is also a very good general resource for COVID and return to sport. So why are these, not just universally applied and we can all say it's great? Well, in my opinion, and maybe that is shared with some other people, there are some potential limitations of these guidelines that I've just given you. Firstly, and I've said this before, there are no data to support them. So that's the one problem, and that's nothing's changed, and will not probably change until we get the data. However, some of the maybe limitations is that they're very specific for COVID-19. And as I've indicated earlier, not always do we know the COVID status of an athlete with a recent acute infection. The third issue, perhaps, is that they are at this stage very disease organ centered. In fact, all of these ones, with the exception of Keith Stokes, doesn't really mention any other system other than the cardiovascular system, and in particularly the cardiac pathology. But of course, we know this is a pulmonary infection. And I'm going to come back to the multi-organ involvement of COVID. The data on which the decisions are based on these guidelines is not on athletes, because we haven't got any data. They're based on data from individuals that were admitted to hospital when it comes to comorbidities and how common these are. And we know that, you know, more than 80% of high level or general athletes are younger, generally less than 35. And probably, and we have some, you know, anecdotal data from studies that done where testing has been done, that many athletes have got asymptomatic disease or very mild or moderate disease. So in my opinion, again, there are a few basic requirements for medical decision-making in an athlete with an acute respiratory tract infection. And these are things that we need to be aware of. And we'll come back to the word aware a little bit later on. So firstly, as I've mentioned before, we have to consider that other pathogens may or may not be involved, either as co-infections or the actual infection. Then we also know that moderate to severe illness with multi-organ involvement is not only a feature of COVID-19 infection. It is well described in other viruses, including adenovirus, influenza virus, and a few others. We also know the multi-organ involvement is, as I've said, not only cardiac and pulmonary, but it has many other systems involved. The other issue, which I've also alluded to, is any guideline has to accommodate the entire clinical spectrum of illness, from asymptomatic to mild to moderate to more severe. And then I guess the one big guideline that's not present in these current protocols for me is that the final test as to whether an athlete can go back to sport safely is to observe what is happening during exercise. And so these guidelines do not really have exercise testing as a routine. And then the last thing, which we're also gradually beginning to understand with some infections, and COVID-19 particularly, is that subtle underlying more medium to long-term organ injury or damage is a feature of the disease. And this may only be unmasked as the progression of the training load after you've already cleared the individual can unmask a subtle symptom or sign. And we need to be aware of that. And I'm not seeing those in the current protocols or guidelines. So as I've said, the final test is a normal physiological response to exercise. And this slide, some of you may have seen this slide, I've used it before. It's not comprehensive, but it's just a graphic depiction of the multi-organ physiological response to exercise. And what I've done in the next slide is to show you the multi-organ involvement of COVID-19. And again, I just want to make the point, this is not the only virus that does this. But this is a very good summary or a review of the multi-organ involvement from a publication just a few weeks ago. And it also gives the prevalence of the involvement of various systems. And of course, the pulmonary system in this case would be almost 100%. The cardiovascular is up to 50%, and so on. But notice the hematological system, the vascular system, particularly coagulation disorders, muscle can be involved in 1 in 10 individuals, gastrointestinal system, the renal system, and all these systems are very important for a normal response to exercise. So, taking all of this into account, what is perhaps a reasonable approach? And again, this is my opinion, together with people that I've worked with, like Carolette and Kelly and so on, have helped. I want to share the 5-step approach that maybe is helpful as we speak. The first thing is that it is a very normal medical approach of getting a really good history with the purpose of that history to assess the severity of that acute respiratory infection. Then to conduct a comprehensive clinical assessment and maybe focus that a little bit in more detail on the residual evidence of any infection. And then a key issue would be to concentrate more and more on multi-organ injury, and again to confirm the severity of the infection. And then a series of additional laboratory special investigations dependent on the suspicion of how much and what multi-organ involvement is perhaps needs to be excluded. And finishing off with a graded submaximal exercise test to make sure that at least in that stage of the progression of the return to play protocol, we can start to unmask any residual symptoms and signs. And then to kick those athletes where there are some symptoms back into the system of reassessment. And in step number 5 would be the implementation of a graded return to play. And then the key would be, and this is where our colleagues, the biokineticists, sports scientists, coaches, even the athletes should understand that ongoing monitoring, particularly of new symptoms, is probably something which this disease has emphasized for us, and we should apply that into a return to play protocol. So let me take you through a flow diagram, and it's complicated, I guess, in some sense. And you know, I'm sure you'll be able to get the slides, you know, about this. You can have a look at it at your leisure. But it starts off now with an athlete with a history of an infection. Take a good clinical history, concentrate on the history of the symptoms, and I mentioned those 3 things: type, severity, duration. The treatment that was required will give an indication of severity, so will comorbidities. And then if there are any laboratory tests or results that were done at the time of the acute illness, to review those. And then broadly say, well, this is a mild or even asymptomatic athlete, or more a suspected moderate or severe acute respiratory illness. The next step is then to get them into your clinic and do a comprehensive clinical assessment. And I'm not going to go through the details, but again, the focus here would be to try and get the actual pathogen, particularly if there was a moderate to severe illness, if possible, and certainly perform a good clinical assessment to check for evidence of multi-organ involvement. So let me go through the kind of 4 groups of patients. The first one is the person who's completely asymptomatic and maybe even was asymptomatic through the entire process, or was really just very mildly symptomatic. So this is an individual who is, after your assessment, asymptomatic, or maybe at worst has mild residual localized symptoms with no infection, active infection, no organ injury. Pathogen may not be known, but is not associated, if it is known, is not one of that is associated with a high risk of moderate to severe illness. And then I would suggest that we do a graded submaximal exercise test. And it's very important to document symptoms, and various scales can be used, like the rating of perceived dyspnea, rating of perceived exertion, heart rate, of course, at rest, exercise recovery, blood pressure response, etc. And at the end of that, the decision can be made. This is, and there were no abnormal symptoms, no new symptoms, and a completely normal expected response. And in that case, one can go to step 5 and implement the graded return. And again, I just want to emphasize it doesn't end there, but it's important to look for new symptoms. This may also be the case for a more mild acute respiratory infection, which at the point after the clinical assessment is asymptomatic and would also go into this green stream, if you like. And so even a moderate, being somebody who's had more prolonged symptoms, more severe symptoms, but not required any hospitalization and so forth. What about the moderate group, or even the mild group that has residual symptoms or signs suggestive of either an infection or some other suspicion of multi-organ involvement, or it may be even a known pathogen that can be associated with a high risk of moderate to severe illness? That's the orange group, and the orange group is required to then go to the step 3 laboratory investigations. And the nature of those investigations will be dictated by what is the suspicious organ involvement. So if it's cardiac, then there's a stepwise progression, very well outlined by the published protocols on resting ECG, exercise, echo, 24-hour ECG, cardiac MRI, and bloods like troponin, etc. And I'm not going to go into details, but the pulmonary one would be chest X-ray, spirometry, pre and post exercise, a CT chest, and other further tests like diffusion capacity, etc. if needed. And then the other organ systems depending on the suspicion. And depending on what the outcome of that is, if it is abnormal, then it clearly requires management of the condition that's now diagnosed and then a reassessment. At this point, there's another way to get back into the reassessment line, and that's going from an exercise test, step number 5, that is abnormal. That would also require a management and reassessment. But if those laboratory investigations are normal, they go into the green group, asymptomatic or mild residual symptoms. And if an exercise test was not already done as part of, say, the cardiac involvement, then the exercise test will be done. And again, it goes into the algorithm. So this is our current approach at SEMLI. And I want to finish off with a case that is actually one of our cases. In the first case that we saw at athlete in our COVID recovery clinic. This was a 23-year-old male elite athlete. I'm not going to give any more details about the person, who 28 days ago had a presentation of rhinorrhea and a scratchy throat, who was initially just assessed but had a COVID positive test because of the high index of suspicion, turned out to be positive. And then over the next 5 to 7 days, symptoms progressed to a fever and chest tightness and then shortness of breath at rest. He was treated out of hospital, so it didn't require hospitalization. And then the symptoms gradually decreased and had a negative test, a repeat negative PCR test 14 days later. So currently, at 28 days, when this individual was seen at our clinic, had a residual symptoms of chest tightness at rest and even at low intensity exercise. And so what is the issue in this particular case with respect to return to play? So this is the pathway we followed. It will be going through the blue ones. We did a history, good history. And because of the duration and the nature of the symptoms, we classified the patient as moderate, suspected moderate, performed a clinical assessment, full clinical assessment. We knew the pathogen, it was COVID, and it was confirmed as a moderate acute respiratory illness. And then the next blue box at the bottom that indicated that the issue of residual symptoms was positive, and therefore we had to go to step 3, the laboratory investigations. And in this particular patient, it was mostly because of the nature of the symptoms focused on the cardiac and pulmonary system, and he underwent a resting ECG, exercise ECG, spirometry pre and post exercise, and a chest X-ray, which all turned out to be normal. And so then we could get the patient back into the green box on the left-hand side, and then we could use the the exercise test results to also make a decision that there were no abnormal symptoms or signs and a normal response to exercise. And that patient is currently in the left bottom box of step 5, where we're about to implement a graded return to play protocol. We are still going to investigate his muscular and neuromuscular control system, but that will be a next step and just before we grade him to start resuming training. So this just gives you an example of perhaps how such a protocol could be implemented in a patient. And we certainly have set up a athlete COVID recovery clinic at SEMLI to precisely deal with these patients. So let me finish off then just with a few concluding remarks, and then hopefully we'll have some questions. We all face a very challenging time in an ever-changing landscape right now. Probably what I say today will change tomorrow. And the medical decision of returning to play, certainly as we have it at the moment, is to advocate a stepwise approach. The severity of the illness can be grouped probably into about 4 different groups. We may or may not know the pathogen, and probably increasingly so in South Africa over the next few months, we may not know the pathogen of the mild, moderate illness in our athletes. We need to consider multi-organ involvement, which could be obvious or particularly also subtle. This is a multidisciplinary team approach. It's shared decision-making with the athlete and the coach. I think the value of a graded exercise test is important, and I want to emphasize the ongoing monitoring of these patients. But the key is that we really need research and research data. So we can discuss this maybe, Shona, if somebody has interest in this, but we've initiated an international collaborative AWARE study. The AWARE stands for the Athlete with Respiratory Infection, and we have 2 parts to that. And that's about to start in the next, in fact, the next week or 2 for part 1 of the study. So let me finish off there, and thank you for your time. And I'm happy then to, answer any questions together with the rest of my team.
Yeah, thank you, Martin. I mean, that's hopefully that answers a lot of questions. We had a couple of questions that came through in the beginning, and I was hoping that your presentation would answer that before we kind of got to them. But maybe just to bring Kelly in here with that case study particularly. I mean, Kelly, your involvement and measuring some of the specific things that you were involved in, could you elaborate a little bit more there from perhaps an exercise science or biokinetics sort of point of view?
Thanks, Joan. Yeah, and as Prof. Martin alluded to, the gold standard is to be in a fortunate position like ourselves to have, a resource-intensive situation where we're able to do ECGs, pulmonary function, and get the really scientific data. But apart from that, there's really important stuff that can be done. And just like what Prof. Martin said, is with the monitoring. So for example, what we're doing with this case study is using something like a rating of perceived exertion, so an RPE scale, matched with intensity of training. So this particular athlete actually started training or tried to start getting back into some sort of exercise 2 weeks ago. And so I asked the question in the first week, what was the average intensity of your training? And it was 30%. So 30% of his maximum, really, really low intensity. But the RPE was a lot higher, so that was 5 out of 10. And RPE, just to shed some light on that, that's how hard the sessions felt. So the intensity was really low, but it felt really hard, or harder than it maybe should have felt. And same with the second week. Intensity of the training session increased to 40%, but the RPE increased to 6 out of 10, which alludes to a hard effort. So this is one monitoring tool that we're gonna carry through as the athlete returns to sport and can be implemented in any situation. Along with that, and yeah, I'm just going to touch on some of the practical things, especially with the monitoring. Having a baseline is, again, an ideal situation. So we can't obviously undo the time now with the COVID situation, but ideally any monitoring that can be done starting from now, whether athletes have a risk of COVID or symptoms of COVID or not, to do the monitoring now, so that in a case where an athlete does present with symptoms, it might be COVID, it might be something else, but at least you have a baseline to compare to, and then you can do some measurements. Some other measurements that we do are monitoring of well-being. So things like fatigue, energy levels, motivation levels, stress levels. And that's just like a daily check-in that we can do regularly. And from that, calculate what we call a Z score, which tells us if there's any deviation from the athlete's normal. And the same with session load. Every session an athlete does, how hard was it, intensity, and what was the RPE? And from that, we can also then over time work out a training stress balance to work out acute chronic loads. And I mean, that goes down a whole other path. But in terms of COVID and returning to sport, monitoring is key. You can use tools like RPE and intensity. And I think maybe Dr. Karolek can touch on a bit of progressive return to training. Some of the things we've told the athletes about, okay, maybe do 50% and check how you're feeling. I'll pass over to Dr. Karolek for that.
Doc, you take over there. Yeah, thank you.
Thanks, Kelly. Yeah, I think the key is just it must be a gradual return to play and monitoring every single step of exercise. What is, as Martin said, what are the residual, what symptoms are experienced, and are there any new symptoms coming through when you start at a low intensity exercise as return to sport and then gradually increase it. So I think it's really important what Kelly says is key. It's sometimes basic monitoring. If you don't have the special equipment, monitoring is key, and a graded return and monitoring all the way through. I just want to add something maybe to this as well. What Martin touched on is just to remember that for me, what stands out as key is just the way we approach any athlete from now on with a respiratory tract illness. If we are fortunate enough to actually identify the pathogen, it would be ideal, obviously, but in many instances there are just not the capacity to do so. But within that, also to remember, as Martin said, everybody in this pandemic is potentially COVID, and we have to maybe treat them as such. But then with that, we must almost remember all the other pathogens. And with saying all of that is like when a patient, I think with the last 18 months of study that we've done, one thing that we really learned is that when you examine somebody with obvious respiratory illness, is go through symptoms, head to toe. I almost want to say when somebody presents to you now with a bit of a cough and a sore throat, my approach would be look at them from head to toes with certain checklists in place. So zoom in on, for example, your meningitis checklist, ask them specifics about their headaches and certain symptoms, regarding meningitis, and go and look for it in your clinical examination. When it comes to myocarditis checklist, go and ask for specifics and go and look for it clinically, although they just present with a cough or a sore throat, remembering that not just COVID, but especially COVID and loads of other pathogens can cause multi-system organ. And so the approach has completely changed, and just having with monitoring as well, picking up new symptoms and then go and look at the possible system that might be involved within that.
Thank you, Doc.
Yeah.
I think that's all really, really key. Sorry, Carl, did you want to add something there?
No, I was just going to say, with so many unknowns, the key, I guess, is to reduce the unknowns. So there is things that we can know by implementing things like monitoring, and that in itself reduces that. There will always be something unknown, but take anything that you can monitor a team of athletes with, a strength test, for example, even a basic push-up test will give you an indication. And as long as you repeat that at regulated intervals for those same athletes, you will always have a comparison that you can compare your athletes to and be able to reduce the unknowns.
Yeah, exactly. I mean, Martin, you mentioned that AWARE study, and I think it's just really key. I mean, this is a global pandemic, and so it requires a global kind of collaborative efforts. And I know that we are very open to collaborate in some sort of way. Maybe could you elaborate a little bit around those studies? And I mean, I've popped it into the chat there, but if anyone is interested in getting involved, whether they have subjects or athletes who have tested positive or want to get involved from a research point of view, to maybe email us at info@semli.co.za. But Martin, can you just maybe elaborate a little bit on those studies and really what we're looking at and how people could perhaps get involved?
Sure. Okay. Thank you, Shona. Look, the two studies are part of two studies that we've identified within subgroup 7 of the IOC consensus that are designed to fairly rapidly give us information that we really desperately need. So the part 1, the first study, is about assimilating as many as we can cases of athletes who developed a respiratory tract infection, which could be COVID or not COVID, depending on whether they know and have been tested, and defining through that study those spectrum of presentation from asymptomatic up to really severe, tracking the symptoms and the time course, and then most importantly, tracking what happens to them as they return back to training, in order to identify how many have got symptoms and signs of comorbidities, how does that affect training, what is the training response, and can we identify some of the reasons why athletes do not or do have a better training response, maybe based on the way they presented to start off with. So that's an international collaborative case series, and we are very well advanced in initiating that. We've got the full protocol done. We've got the tool that will be able to be applied. We're in contact with a number of international collaborators on that. And anybody in South Africa that is wanting to maybe contact us to find out more about that, we're very, very happy to talk to them and work with them. Particularly maybe if you're looking after a large team or are responsible for one of the federations and so forth. So that's the first study. The second study, which I'm not going to speak too much about, is related to effectively what we're doing at the SEMLI COVID Recovery Clinic. And this would be, how do we take these athletes with COVID infection, and what sort of tests show what to us as they progress. And that's more a group of people that have got access to some diagnostic and laboratory equipment, and that's a so-called prospective cohort study of COVID athletes, and we're looking at that over the next 6 months or 12 months, again as an international collaborative research project.
Awesome, thank you, Martin. I think let's maybe take a few questions from the floor if we can, and maybe we're also kind of getting used to this via correspondence way, and I know there might have been some issues to some people logging on, and we might have reached the cap every now and then. But so for those who are joining us via the Facebook pages, we will get to questions as best we can, and we will obviously offer you guys your CPD points as needed. But Martin, there was a question that came in here on the Zoom link. It's that you mentioned about the SEMLI COVID Recovery Center, but what is the kind of advice that you would give to perhaps places or clubs or teams who maybe don't have the resources that we have, that we're privileged to have? How do these clubs maybe take their testing and monitoring forward?
Okay, so again, I think the decision making, the 5-step decision making, would be the same. And that doesn't require enormous amount of resources to at least implement the principle of the 5-step recovery or the 5-step process. Where perhaps the issue comes in is when there's a suspected more severely affected athlete and they need to go to that box number 3, which is the special investigations. And the current recommendations internationally have got a very low tolerance to do lots of special investigations. And that is where we really need information as to which of those are really, really necessary. So if you have an athlete in a low resource setting that requires those special investigations because of your history and examination that requires that, you're really at this stage, you need to maybe look at, identifying individuals or groups of people or resources where you can have those athletes be seen. It would be not a good idea to have an athlete who has really had a severe infection progress with training without having the necessary investigations. And again, it's specifically the cardiac, the pulmonary, and the vascular that is probably those key areas. So that's the best advice I can give, related to that.
Okay, no, that's awesome. Thank you, Martin. There's a question coming from the SASMA Facebook page, and just give me a second to read through that. It's from Sarah Ferguson, and she's asking, in a case with an athlete who tested positive for COVID at 21 days, retested negative, still had symptoms of high heart rate and shortness of breath, had a resting ECG and chest x-ray, which revealed post-viral pneumonia and acute myocarditis, was booked off for 6 more weeks, is now doing a slow graded return to sport. Too much activity elicits any kind of mild symptoms. What would be your advice? And I think she's also following on with that with saying, how accurate is using heart rate for exercise in a graded return to sport? Is that completely safe?
Okay, so I'm going to have a quick answer to that. Maybe Caroline can chip in. If I understand the history correctly, the patient ended up having a myocarditis, and there are international, return to play guidelines from Europe particularly, and others that give us guidelines on myocarditis. And the time course for recovery from myocarditis is usually longer than 6 weeks. So I wouldn't be too surprised if this athlete still has symptoms. We obviously don't really know too much about the recovery from a viral myocarditis from COVID. There are not that many cases, not in athletes. So I would say that, this athlete needs to have a very conservative approach in the next even up to 3 months after. And I would involve a sports cardiologist in the decision making. Okay,
awesome. Doc Carolette, anything you want to add there? You all good? Happy with Martin's response?
Yeah, of course I am.
Okay.
But I also think the key. I understand that mostly we resource limited. I mean, if you live in the Western Cape now, you're not going to get a COVID test very easily. So, I think the key is just to be a bit more conservative. Myocarditis is actually a no-brainer to be really conservative about that. But if you suspect it, and if the clinical signs, then you can't test for it, with this pandemic that we're rather on the side of caution, just because of all these systems that can be affected and long-term effects. There are quite a few long-term physical and mental effects on athletes, on people after COVID. So I think the key, and it's difficult within an athletic environment because they had to be better by yesterday already. But I think the key is just to be maybe conservative, especially if you don't know what you're working with, and all the more with a myocarditis, even more conservative approach than to rush things through and pay for consequences later.
Awesome, thank you, Doc.
Yeah, I think. Sorry, Shane, can I
jump
in there with the? Just touching on the heart rate question. I think classic answer of it depends on so many variables. The gold standard in our practice is to use a 12-lead ECG, and if that's used, then of course heart rate is very accurate and a good measure. But in a more practical setting, most athletes, if they, at some sort of professional level, you generally have a sports watch of some sort. And again, it depends on the type of sports watch and how it's worn and everything will affect its accuracy. But again, it's reducing the unknown. So rather measure it and know it than not measure it and not have that to use. And not just measuring something like average heart rate during a training session, but resting heart rate specifically when they wake up in the morning, just before they train, middle of the training, end of the, you can just increase the monitoring, and especially recovery heart rate. Again, coupled with RPE and something like session intensity can start to give you a bigger picture of how that athlete is doing. And if you do that in bite-sized chunks, so 3 days, let's train at 50% intensity and see how you feel. If there's symptoms that come up, then you refer up the chain to the sports physician. But take it literally step by step and using what you can. So heart rate, I would definitely recommend using that measurement.
Okay, thanks, Cole. Martin, I want to direct this one at you, and you and I have had this conversation in terms of directing some testing that we've perhaps been approached to do. But Brandon's asking here. He says, "I see you recommend spirometry. Most of the international and local societies recommend against doing spirometry, and I know you and I have had some of these conversations. What is your kind of go-to around just a normal lung function versus exercise lung function? How can we be performing best practice in that regard?"
Okay, Brandon, thanks very much for that question. I read that question, and you're 100% right about the advice on spirometry not being universally accepted. However, particularly in athletes, it is important. I've got a colleague that co-chairs the subgroup 7 with me, James Hull, as pulmonologist from Royal Brompton in London. And James makes a few very good points about this. He would firstly say that a fairly large percentage of high-level athletes have got exercise-associated or exercise-induced asthma or exercise-induced bronchospasm or actual asthma. And so asthma is not an uncommon comorbidity. So that means that spirometry pre and post an infection is not an unreasonable investigation for somebody who remains breathless. Second reason to do it would be to consider post-infective bronchial hyperreactivity as one of the causes potentially of shortness of breath and chest tightness and coughing. So although the very few very few cases that we know about COVID show normal spirometry pre and post COVID, in athletes with symptoms, particularly shortness of breath, chest tightness, wheezing, dry cough during exercise, spirometry is recommended. Certainly, from the pulmonary guidelines for post-COVID return to play guidelines.
Thank you, Prof. There's another question here coming from Dr. Lee Pillay. It's good to have you here, Dr. Pillay. I'll just read it out. The challenge at the moment is the persistent positive case in the mild to moderate COVID-19. He's asking for your advice in this regard. Obviously, the worldwide opinions is to ensure there is a negative test prior to progressive return to play with the daily symptom monitoring. So, sorry, that is quite read out just word for word, Martin, but if did you get that? If you can maybe give your advice with regard to that.
It's very interesting. Just this last Friday afternoon, I have a special group that we convene every Friday afternoon at late afternoon and discuss around the world sort of what's happened with COVID in athletes. And part of that group are professional, the professional European and in particularly the German football team physicians. And we discussed an ongoing negative test, and an ongoing test that's positive, even though they passed the 14 days or 21 days post-infection. And the majority of the opinion at the moment, and I'm not an expert on virologist, but the majority of the opinion at the moment is that after 21 days or so after infection, a positive test is likely to be a false positive test in the majority of cases, particularly if there are no further symptoms. And the German football, if I understood their advice correctly, is they let those players play. There are ways in which you can try and make sure that, that perhaps the test is, you can repeat the test, of course, until you find a negative test. Antibody testing is very much controversial, not because the concept is controversial, but because the testing is not that accurate. So most of those entities, those organizations, take blood and they store it for later antibody testing until we're much more sure about that. So the answer is, ideally we'd like to have a negative test. If you don't have a negative test, repeat the test. If it's still positive and it's really more than 21 days, you're probably fine. And the player, certainly in some instances, professional leagues will let the player go back to play. The chance of them shedding virus is very low.
Awesome. Thank you. Thanks, Martin. Dr. Pillay saying thank you very much there.
No,
So,
no,
guys,
but he knows we've discussed this before, Lee.
Yeah, so, we definitely have. So,
yeah.
No, I'm glad. I enjoy the interaction. And I'm glad that everyone on here has enjoyed so far. I think maybe just one last question. We have 2 more minutes. And yeah, I know we did have a few issues, so apologies for that with the people who couldn't get to join. We will make this recording live and put it out and send the link to everyone. But maybe the last question, Prof, is, there's obviously some athletes have pre-existing conditions, and I guess some of it is endurance-specific athletes, with exercise-induced asthma. Do those athletes require extra kind of precaution or different kind of interventions along this? Taking into account the COVID pandemic, or how would we treat those athletes?
Yeah, I mean, I think so. What one's talking about there is the risk potentially of more severe disease in an individual who's got pre-existing comorbidities. And I think those kind of athletes one will have to, take on almost a case-by-case basis. I'm gonna put this question to Caroline, because Caroline has an interest in a very special group of very important athletes, the para-athletes. And maybe Wayne can bring in an opinion as well. Wayne will have to be via typing something. But I mean, that's a group of athletes that we would almost regard as a little bit more vulnerable because of their pre-existing comorbidities in this. And we absolutely have no data on that. And part of the AWARE study is that I have already spoken to Wayne. Wayne's going to lead that hopefully through the IPC to get more cases on athletes, para-athletes. But that would be one group that I would say are we need to particularly look after them well. Maybe Caroline has a final point on that.
Yeah, Dr. Caroline, maybe you comment, and then I see Wayne is still on here, and I can unmute him if he also has a comment as well. So Caroline, maybe give us a shout, and then I'll unmute Wayne as well.
Sure, thanks. Definitely, they're in any case a very special group of athletes that are dear to everybody that gets involved with them, will fall in love with them immediately. But they are generally older people as well. So, and just not with their disability. If it's a physical disability because of trauma, it's one thing. They might have an underlying, there might be no other comorbidities. But usually, they're an older group of athletes. They are, and loads of underlying medical problems. So definitely a group that we have to look out very carefully for and that's what Martin also said, make sure you know your athlete really well and know about every single comorbidity that they have, to look out for symptom progression then as well. So if they do become ill, really monitor them very closely to see how they progress, and make sure you know what's going on with them in their medication wise and comorbidity wise. Wayne?
Thanks, Doc. Well, yeah, Wayne, anything specific from your side you want to add to that?
Well, Carolette answered it very well. I think the important thing is just to realize that this is not a homogeneous group. So in the para-athlete group, you get a lot of people. The majority are not at increased risk. It's actually quite a small minority that actually are the group at increased risk. And this would be some of the spinal cord, the high spinal cord lesions, where these athletes can't breathe properly and have breathing issues to start off with. They might also be immune compromised. And really, those athletes are the ones that one needs to watch out for. I think some of the other challenges are things like social distancing. How if you're visually impaired and you've got a guide, do you social distance? There's a lot of anxiety about the equipment that you use. How do you keep on keeping your prosthetic leg and your equipment and your wheelchair and all of that clear of contamination? So those are the subtleties that we're now certainly looking at mitigation strategies to a lot of those things. But yeah, I mean, it's different strokes for different folks. Thanks, Jonah. Over.
Awesome. Thank you, Wayne. Okay, I think yeah, the hours struck, and I am cognizant of that time, and I know where there are one or two questions. I mean, Grace, I see there's a question from you, and it's around social distancing, around exercising and droplet spread, and both Kelly, Carolette, and I were on a recent webinar around, particularly around lab protocols around this. So we will definitely get to these answers. And if we're not going to get to them live, but we will put up these answers and make sure that everyone does get their questions answered. But let me just say, so thank you to everyone for joining. I think it was a great discussion, and hopefully the start of very much a collaborative effort around ensuring that our athletes a safe return for our athletes post this pandemic. And so Martin, Carolette, and Kelly, thank you very, very much for your time. I think I've muted all of you. Sorry, let me unmute you guys. But yeah, thank you very, very much for your time and your inputs. Yeah, hopefully we can do this again soon.
Thank you.
Thank you, Shona. Thank you, everybody.
Yeah, thank you, Shona. And I think good way to end, considering next week we do plan to do our talk on disability sport.
Yeah, exactly. So keep in tune with the SEMLI Facebook page from there. We are looking at a talk on disability sports, and we'll keep you in the loop there. So join on the SEMLI Facebook page, and then we will be linking up with Tuck Sports as well, and doing a couple of talks around mental strategies and all sorts of getting some input from the coaches. So big thank you to SASMA and their partnership as well as to Tuck Sport here. Yeah, I think moving forward, it requires a collaborative effort to ensure safety of our athletes from here. So thanks very much, everyone, and have a good evening.
Thank you.
Thanks.